Myself and Sengman Wang came up together with a solution to the question. And so I'm going to present some very preliminary data that we jointly have put together to address the issue of how we can identify abnormalities in neural mechanisms from the MBS. So what might the MBS tell us? We certainly know about volitional initiation of swallowing, and we can identify that from the MBS. Sensory triggering seems to be one of the components in initiating swallowing, as well as the volitional initiation from the cortex. And then, of course, we know that there is a component of the brainstem central pattern generator in programming the swallowing. So this is a diagram of that conceptual concept of the central nervous system and how it controls swallowing. You have cortical initiation, which is stronger, particularly when we're in the MBS situation where we say swallow now to the patient. Clearly, they're probably using some cortical mechanism to initiate that. There is the bolus, the sensory input, down here as number 2. And that is having an input. We've already put the bolus in the mouth, and so there is a sensory input there as well. And then there is the central pattern generator that might be triggered both by the cortical input as well as the sensory input. We know that sensory input is bilateral. Even if you initiate sensory input on one side, you will have projection of that sensory input to both sides of the cortex. And so, although that may not be the initiating event in every case, it certainly can contribute to cortical initiation as well as brainstem patterning. So conceptually, we're talking about the nucleus tractus solitarius being the input to the ventral swallowing group, and that both cortical inputs and peripheral inputs drive this central pattern generator. So what can we study about that model, excuse me, using MBS? And certainly people have measured timing. The onset of the pharyngeal phase, of course, is one aspect that people measure. The patterning of when they start to raise the hyoid and the larynx. And if I'm assuming central control that I want to measure, I'm going to assume that the peripheral system is intact and that the motor nerve and the structural system is intact. And I want to see whether I can study something about the central control at the cortex or the brainstem based on the measures from the MBS. So I'm borrowing in this presentation from studies of gait analysis that are used by biomedical engineering. And there's been a great deal of work in studying gait using measures of kinematics. That is, the movement, the displacement over time of different structures. So there are phases of the gait cycle, and it starts initially with the impact of the heel on the surface, which is part of the sensory input to the walking system. And there is cortical initiation for the subject to move forwards, and there is also a pattern generator for walking. So there are some similarities in some ways to the gait cycle as there are to swallowing. You also have phases within the gait cycle, in the initiation of double support, then the right legs swing, and then double support followed by left wing swing. So you can divide up the gait cycle into different parts or components or patterns that is fairly invariant and can allow you to study that. And in fact, you can even look at when different muscles come on and during that gait cycle. And if you remember some of the work that we've seen in the past by Doty, where we showed the pattern of different muscles coming on in swallowing, you can see that there are some similarities between the gait cycle and swallowing. Well, Becky Leonard and colleagues have done wonderful work on swallowing, looking at different phases in swallowing and the invariant order of those phases. And here's a diagram from their data showing the different components of swallowing and how these follow in a relatively invariant sequence. So again, we have a cycle that if you look at the full swallow and all the events that occur, they can be sequenced. And here are some measures that they did from their patients and found that there could be a sequence of different components. And if you measure the duration, you can see that some components are longer than normal. In this patient in particular, the air closure cycle was much longer than it was in controls. Similarly, if you look at displacement, that is the amount of movement range that occurs, how many centimeters a structure moves, you can measure the patient relative to the normal data and determine whether the patient is moving to a lesser degree than normal or to a greater degree than normal and has more variance in certain components of the cycle. So we want to look at another aspect of that. Looking at the gait cycle, if you look at knee angle over time, you can see that the knee angle changes at different phases in the gait cycle. And so this gives you the displacement or the angle of movement over time, and you can look at how that is variant or invariant over time during a walking cycle. So taking that concept, we want to apply the same concept in our thinking of swallowing. Now, what people have found that there are, you can take means and standard deviations for the motion over time. So I just showed you knee angle. Here's angle of the ankle. You can also do the actual timing and power of the different motions that are occurring during gait cycle, and you can conceivably do the same thing during swallowing. So this is work that we did using a motion analysis system from the MBS. It's called Peak Modus by Vicon. And you can track the position of structures over time, and your resolution is the time between the different frames in the video of the MBS, which of course is around 17 milliseconds. You can study the initiation of the cycle using a definition, and we decided that a definition would be relative to the bolus position because you don't want to do it relative to the movement of certain structures if the movement order of certain structures is affected. So for the onset, you could use the sensory-driven input because of the bolus, due to the bolus, and use that as your initiation. So the onset relative to the bolus position, say crossing the mandible, and then the offset relative to the bolus crossing the UES. And to be able to capture the full motion, we used 1 second before the onset of the bolus hitting the mandible and 1 second after the bolus left the UES. So this is the kind of analysis that we can do. I should mention that these trajectories are smoothed because the Peak Modus system allows you to do low-pass filtering, and we found that 4 Hertz was particularly helpful in allowing us to look at the movement trajectories over time in a smooth fashion. So here you have the larynx in the elevation position, and here's my, okay. So here you have the larynx and the, in the Y position over 2 sequentials, 2 swallows at different times to look at how reliable this individual, who is a normal subject, is in their pattern of larynx elevation over time. You can also look at the elevation of the hyoid over time for 2 different swallows. You can look at the hyoid in the anterior position over 2 swallows and the larynx over the anterior position. So you can look at motions in elevation and motions in anterior to posterior over time in an individual, and you can see that this individual, using the same type of bolus, had a very reliable pattern of their swallowing. The second individual was much more irregular in some way in the timing of when their peaks occurred and when their onsets occurred, both for laryngeal elevation as well as for hyoid, and the anterior position was particularly different. Now, one thing that they do in looking at gait cycle and the patterning and how regular the central pattern is they normalize the time of the cycle. And so here is a gait cycle where they've taken the onset of the footfall and the onset of the next footfall and used that as 0 and 100%. So you're squeezing everything into the same time. And remember, we're using our onset at the bolus at a certain arrival at the mandible. And so you can use that as plus 1 second before that, using that as your 0%. So here we've done, this is the trajectories of the hyoid and the larynx in the anterior position in 4 different subjects over time. And then when you normalize and put the time all from 0 to 100%, you can see that you get a much more regular patterning between different normals for the anterior position of the hyoid. So this is displacement over time, and you can see that the peaks line up very closely when you normalize on time. The larynx in the anterior position, of course, is much smaller movement and differed much more between individuals, both in amplitude and in the timing of that occurring. And clearly you could normalize based on the different lengths of the spine and the difference between the different vertebrae, as Katrina Skeel has done in some of her work. But if you look at normalization over time, you can see then that these peaks line up much more closely, and so there isn't such a difference in the timing of the pattern when you normalize. So the questions we wanted to consider is, first of all, we think that the elevation of the larynx is somewhat dependent on the motion of the hyoid, and so you could look at these 2 displacement patterns over time and determine that. We also wanted to examine if there's a consistent relationship among normals and whether there is relative patterning of timing between the hyoid and the larynx, because this would tell us something about the biomechanics of how movement of one structure might be confined or dependent on another. Finally, you can use the first derivative, the velocity tracing. As it leaves 0, you can identify movement onset in a fairly objective fashion. And in this way, we could look at whether the central pattern generator is similar across normal, healthy subjects. So this is very preliminary data on this question. These are velocity trajectories, and you can see that the velocity trajectory here for the hyoid and for the larynx are somewhat independent and occur at somewhat different times, the red arrow being the onset of the hyoid and the blue arrow being the onset of the larynx. This patterning is different, though, in some of these normal subjects. You can see that the timing of onset here, if you do the trajectory, is different in this subject than in these other subjects. And you can see that this patterning is somewhat splayed out, even after you've normalized for time and lined up everything according to bolus condition. So this suggests that there's a fair amount of individual differences among normal folks. So if you see individual differences in the elevation onset of the hyoid and the larynx relative to the bolus in normal folks, can you then use these kinds of analyses to tell you if there are central patterning abnormalities in patients? So in a very preliminary way, I'm going to show you some data from 2 patients. This stroke patient, who is relatively mildly impaired, has some penetration, but we know that's not important after this morning. However, there is a fair amount of residual left there in the oral pharynx. This is another patient who's much more impaired and has a much more abnormal pattern. And clearly the first swallow had some problems, and the subsequent swallows didn't improve on that. I'm only going to show you kinematic analysis of the first swallow from both patients. So our normals are in the light colors, and our patients are in the heavier colors. Patient 1 is the blue patient, the blue line, or the purple line, and patient 2 is the dark red line, so that you can differentiate. This is the more severe patient, and this is the milder patient. This is the anterior hyoid movement in actual time, and when we normalize, we can still see that, first of all, of course, the peak displacement is off, but the patterning is abnormal, particularly in patient 2, which was more severely affected. In fact, this patient this patient retracts the hyoid at the beginning of the swallow and also retracts it at the end of the swallow, showing a somewhat abnormal pattern. Here, if we look at superior hyoid movement, again, we can look at peak displacements. You can see that this patient is delayed. Patient 2 is more delayed, and again, goes into this inferior motion at the end of the swallow. Patient 1 also does some of that. And then finally, if we look at the anterior larynx, you can see, although the peak displacements are still in the same range as some of the normals, you get an abnormal patterning at the end of the swallow in particular. And superior laryngeal movement, the second patient who was more severe, clearly lowered the larynx at the end of the swallow, which might make it more vulnerable to penetration and aspiration. So what can MBS findings tell us about mirroring the neural control, that horrible topic that I was given? Certainly we know peak displacement and movement onsets. These are traditional measures and have been used very nicely by investigators. But we also might look at patterning, tell us to identify when there are central patterning abnormalities. These could identify what the patient is doing wrong during the swallow and could be used in rehabilitation. And certainly we need a lot more work to do to examine whether these measures could better reflect swallowing recovery. Thank you.
Well, thank you very much, and I'm very grateful for the invitation to present today. Given the lofty title, I'm sure, by Dr. Belafsky of Try and Fail, but Don't Fail to Try, we've spent a lot of time mulling over how we would attempt to avoid failure in a 15-minute discussion of this very complex topic. And I think our approach at MD Anderson is really to understand the condition and understand radiation as a treatment modality so that we can approach our video fluoroscopy informing our expectations of what we're wanting to take away from that examination as a diagnostic tool. Disclosures are CPRIT, which is the Cancer Prevention and Research Institute of Texas, for fellowship funding and salary support from MD Anderson. So radiation-associated dysphagia, or what we as a group might term RAD, I think is best considered a very unique condition of swallowing impairment. So this is typically chronic. It's, for some individuals, a progressive problem. We know that it's related to neuromuscular fibrosis and edema that occur within the field of the radiation therapy. So obviously this, by and large, affects the pharyngeal stage of swallowing. When we approach our video fluoroscopy, I think it's helpful to simplify by starting to pick up on patterns or common phenotypes of the swallowing impairment. And these videos here really exemplify what we consider. I don't know if it's possible to get the volume turned down on that. But essentially, typical patterns of swallowing function or swallowing impairment after radiation. So when we see problems with airway protection, it's typically impaired supraglottic closure, residual after the swallow that's leading to aspiration when it does occur. And if we look at the pattern that we commonly see in patients swallowing a solid food bolus,
Chew and swallow when you're ready.
It's an impairment in the driving pressure on the bolus, typically from the tongue base being impaired, the pharyngeal contraction being impaired. This ultimately leads to retention of the bolus, obviously, within the pharyngeal recesses, most commonly the vallecula. But these are very typical presentations of what we can identify on video fluoroscopy in our patients with radiation-associated dysphagia. Just to back up briefly for background, I think that we as a group should really consider radiation-associated dysphagia to be a priority area. We know that the number of patients who are at risk for developing this problem is increasing and will continue to increase, and this is because of several trends in the epidemiology of the disease and the treatment of the disease. The number of oropharynx cancer patients is rising. It's projected to almost double by 2030. This is due to HPV-associated disease. And we know that organ preservation strategies where patients are treated with frontline radiation or chemoradiation have become increasingly common in the last 2 decades. So these two combined trends, along with population-level data that show us that the burden of dysphagia in head and neck cancer survivors is highest in those treated with chemoradiation, really create the perfect storm in our clinical practice of more and more patients coming in with radiation-associated dysphagia. And we are not exempt from this problem in the era of IMRT. So intensely modulated radiation has certainly been extremely useful in sparing dose to the parotid glands and decreasing xerostomia, but we know that the multiple beams that are required, so you can see an example here, there are a minimum of 9 beams used to conform or shape the dose in IMRT, and we know that there's actually an unintended dose coverage because of this, whereby structures that we know as swallowing clinicians that are critical to swallowing function, the brainstem, the anterior oral cavity where the suprahyoid muscles reside, even the larynx, receive significantly higher doses in IMRT planning when we compare that to conventional radiation plans. So, first pearl of wisdom on how not to fail is to recognize that not all radiation therapy is equal in its potential insult to the swallowing mechanism. The technique differs. The way in which we spare dose to normal structures differs. Did we use a larynx block? Use of a larynx block can decrease the dose to the lower larynx and the cricopharyngeal inlet by almost half. Are the swallowing specific musculature, the pharyngeal constrictors, the entire laryngeal complex considered dose constraints when we are planning our IMRT? How about fractionation schedule? Are they getting radiation once a day or twice a day? Unilateral fields or bilateral fields? And increasingly now there's the conversation of the particle. Conventional photon radiation delivery, if you look at the blue line here, delivers radiation with a high entrance dose. It delivers its highest dose to the target and then slowly exits the body. So you get quite a bit of collateral damage to normal tissues that are adjacent to the radiation target. If you contrast that with proton therapy, which is only in its infancy in head and neck delivery, you can see the potential for dose sparing, but only for small targets. So we have a very low entrance dose of that proton. It deposits its higher energy in a very narrow range, and then there's almost a complete drop-off of the dose, so that particularly structures posterior to the target are almost completely spared from dose. And finally, we know that chemotherapy, which is very commonly delivered concurrently with radiation, will sensitize normal tissues to the effects of the radiation. So when we're doing our intake for video fluoroscopy in a patient who we're working up for RAD, or radiation-associated dysphagia, our intake needs to differ a little bit from the conventional questions. We need to refine it a little bit. Not only do we need to understand the technique of radiation that was used, but what are the patient-specific factors that make them more susceptible to radiation delivery or radiation-associated dysphagia? Did they get supportive care? Did they perform swallowing exercises during radiation? Were they completely MPO? Did they continue to eat? Have they developed taste aversions? Do they gag? All of these things will impact on the recommendations that you can make from your video fluoroscopy. And we must consider the target or the tumor. This is what's going to sculpt the radiation fields. And so if anything, if we as clinicians can start to think about these two types of patients coming into our video fluoroscopy suite, not as head and neck cancer radiation patients, but they're unique subtypes of their head and neck cancer. So on the left here, you see a patient with T3 squam of the tonsil and their matching fields. And so what you see is that high dose is deposited here in the oropharynx. The tongue base, soft palate, superior pharyngeal constrictors are getting roughly 70 gray of dose. I expect this patient on video fluoroscopy to have problems with proximal driving pressure on the bolus. I'm going to see molecular stasis. But if I go lower down, the nice thing about this patient's fields, I'm not sure where my cursor is, are that the thyroid cartilage, the arytenoids, the cricopharyngeal inlet are also getting much lower dose. So this is a patient who I have less concern about stricture, less concern about aspiration. It's not off the table, but these are things that I can begin to think a little bit differently about. And then if I contrast the way I approach my video fluoroscopy in this patient who also has local regionally advanced head and neck cancer, but it's a very different tumor. This is a T4 squame of the piriform sinus, and you can see the very different dose distribution on the fields here. The entire larynx and the entire hypopharynx are in that high-dose region, receiving roughly 70 gray. The beauty of this individual's plan is that the tongue base and the superior pharynx are getting a much lower dose, so this patient may have the benefit of very good driving pressure from the tongue base downward on their bolus, but I know that once it gets into the distal pharynx that there's going to be more laryngeal edema, this patient's going to have shallow piriforms, I'm expecting a much greater risk of aspiration of residue after the swallow, I'm expecting a much greater risk of stricture. So these normal tissue effects that drive radiation-associated dysphagia certainly occur along a continuum, and I think we can all appreciate that they coexist in time, but there are features that predominate, again, along the trajectory of cancer survivorship. So in a patient's acute recovery, usually in the first 6 months, we see edema predominating on the physical examination in these individuals. That goes on in their chronic phase of survivorship to become a fibrotic process where you see stiffening, hardening, induration of the laryngopharynx. Jan often describes this as contiguous pharyngeal structures. You see that a lack of definement, and those lateral channels and gutters within the pharynx appear blunted, so there's not a lot of reserve for residue to reside in. What we are increasingly noticing in clinical practice and also showing in some of our studies on late radiation-associated dysphagia is that there's a strong element of denervation in these patients who are coming back to us 5, 10, even 20 years later with new onset of really severe dysphagia. These patients have overt clinical cranial neuropathies when you do a thorough examination of them. The end result of all of these normal tissue effects is ultimately decreased mobility of what the Michigan group refers to as dysphagia and aspiration-related structures, or the DARS. And this is the way radiation oncologists think about it, DARS. So that brings us to another common pattern of failure in video fluoroscopy in radiation-associated dysphagia, which is overdiagnosing or over-attributing the dysphagia to stricture. Stricture is actually very rare. Meta-analysis data show us that the summary risk of stricture in patients treated with radiation and chemoradiation is only 7%. So if it's not stricture, or if it's rarely stricture, what drives the radiation-associated dysphagia is impaired mobility of structures within the laryngopharynx. The pathophysiology of radiation-associated dysphagia is largely one of reduced base of tongue retraction, reduced hilaryngeal excursion, and we can use video fluoroscopy to define where the breakdown is in the physiology of the swallow. So if first we're avoiding failure by knowing the disease and knowing the treatment, second we're avoiding failure by picking apart the appropriate pathophysiology of the dysphagia, the third thing, and I think the critical thing that we as a research society have to do, is be able to quantify the impairment. So I can put a number on how this dysphagia here, what we coin as the new normal. It's not a normal swallow, there's some impaired physiology, but there's functional bolus clearance. There's no aspiration, very minimal residue. How can I quantify that that's different than this swallow here in the middle, where clearly the physiology is more disrupted, the bolus clearance is worse, the patient's going to aspirate it here in a minute. And how do I differentiate that level of dysphagia? Here, I'll show you the amount of residue. How do we differentiate this from this profound impairment, what we describe in our clinical practice as a patient with a frozen laryngopharynx? You can see almost no mobility of those structures. Bolus enters the esophagus almost by gravity, and if I pull the video forward to where a pudding bolus is administered, you'll see almost complete stasis of the bolus within the pharynx. This gentleman eats and continues to eat for the past 5 years since we conducted this video fluoroscopy. So in radiation-associated dysphagia, we don't quantify it by their diet or their PEG status. And how we do quantify it from our video fluoroscopy is sort of all over the map. This is a summary table of different measures that have been reported in the published literature from studies of video fluoroscopy in radiation-associated dysphagia. You can see that we're all pretty good at telling you about whether there's residue and aspiration. We all use different measures, but at least we comment on it. We are much different in our reporting of the potential pathophysiology and then which summary measure we attempt to use to quantify. And admittedly, our outcome measure will depend on the purpose of our study, but certainly the use of such a diverse set of outcome measures makes it really hard to grasp at any cohesive bit of information when we go to the literature. At MD Anderson, our approach to video fluoroscopy and radiation-associated dysphagia is to consider it a component of what we call a comprehensive functional panel when we're trying to quantify or describe the extent of impairment. So at the time of video fluoroscopy, we ask patients to inventory their own perception of their swallowing impairment by completing the MDADI, which is a 20-item self-reported tool. The clinician conducting the modified barium swallow study will also rate diet on a standardized scale using the performance status scale of head and neck cancer, and this is an NCCN recommended scale in head and neck. And then we never perform the video fluoroscopy in isolation. It's always done at a minimum with a comprehensive cranial nerve examination, and we find such extreme value in complementing what we see on video fluoroscopy with what we see on stroboscopy and endoscopy. The data that we get from stroboscopy showing us the actual structural change, the vibratory capacity of the mechanism is really critical to informing really when we're talking about our treatment planning. What are we working with here? What can we rehabilitate versus compensate? Just a word of caution, we love patient-reported outcome measures. We use them all the time, but we recognize, and it's shown in the literature, but I think a picture's worth 1,000 words here, that there's a lot of discordance between what we can get from our video fluoroscopy and from what the patients tell us. So this is a modified barium swallow study conducted in a patient after chemoradiation for locally advanced tonsillar cancer. Take another one. You can see that there's clear impairment in the physiology of the swallow. Bolus clearance is inadequate. There's aspiration after the swallow. It's not a severe dysphagia, but it's at least a moderate radiation-associated dysphagia. The patient's MDADI scores on the same day of this examination are at the bottom, 82 for the composite and 100 for the global. We use a minimal cut point for minimal impairment of 80. So if we had screened this patient just with a questionnaire, he would have been identified as having no dysphagia. It's critical that we have quality swallowing measures, not just these patient-reported outcomes in cooperative group multidisciplinary trials where head and neck oncology practice changes. These are largely funded by CTEP at the NCI, and if you actually go to the RTOG website and look up the current activated head and neck trials, there's no video fluoroscopy in any current trial. There is an opportunity for us to contribute to quality measurement of swallowing endpoints in 2 upcoming trials, the RTOG 1221 and the ECOG 3311, and really strongly encourage you to get involved and participate in these measures if you're at an institution that's going to enroll patients on these trials. So I'll conclude by saying that we as a research group, I hope, can define a consensus on what our minimal standards are for the data that we report for video fluoroscopy in radiation-associated dysphagia. And it may be, and it very likely is, that these outcome measures will differ from the outcome measures that we think are critical in other types of dysphagia. I encourage us to participate in video fluoroscopy as an endpoint of dysphagia in cooperative group trials, and to see video fluoroscopy as a component of our measurement tools for really comprehensively assessing a patient's swallowing function. And as a research community, I would ask for us to consider stratifying our video fluoroscopy outcomes by tumor site and by the radiation type, because it's not until we start to part and parcel out the different subtypes of dysphagia within radiation-associated dysphagia that we'll really understand the nuance of the condition. So I'll conclude by just saying that it's an honor to be a part of a really extraordinary team of clinicians at MD Anderson. We're now almost 25 folks strong in our section of speech pathology and audiology, which is under the leadership of our esteemed Gian Lewin. And we're within an amazing group of about 14 head and neck surgeons and about 10 radiation oncologists, all dedicated to the care of head and neck cancer. And it's just an honor to work there every day. And so thank you for your attention and your time.
Thank you very much to Dr. Steele, Dr. Hutchinson, and Dr. Ludlow. We have about 5 minutes for questions, so we have a winner.
Takahashi from Tokyo, Japan. May I ask a ridiculous question, Catriona? American and Canadian people, subjective evaluation against thickness or viscosity is pretty same or equal? Oh, really?
Oh, would Canadians and Americans subjectively?
For example, you evaluate this liquid like nectar, and the others agree with you completely?
I
think that subjective evaluation of viscosity or level of thickness is all over the map, whether you ask in the United States or in Canada. And you've given me a perfect opportunity to put a plug in for a paper at the desk for a new project that is actually hoping to start developing an international template for descriptors of texture modification in dysphagia. So we would love everybody's input into that project.
Thank you. But in Japan, for example,
you
I
have
feel
13 levels or something in Japan.
Probably Japanese food is very delicious and delicate, and there are a lot of super taster in Japan. So different.
Thank you.
Japanese food is very tasty, I agree. We have another question?
Yes. I'm Lisette from the Netherlands Cancer Institute, and I also have a question for Katrina Steele. Because in our institute we use Omnipac. That's another type of contrast. And that's because our radiology department is saying that it's more harmful to use barium because patients have more problems getting it out of their body. Do you know anything about that? Or?
Well, I would gladly defer to a radiologist on this comment. Perhaps Dr. Jones could comment, but my impression from having looked around the world is that there are different preferences. So that in Europe, for example, gastrografin is actually a favorite. In North America, gastrografin is absolutely not considered safe. And so Omnipaque is a hypoosmolar contrast and often used in children, I believe. But Dr. Jones, maybe you could enlighten us.
Actually, there's a very interesting teaching about Omnipaque that may or may not be true. It used to be thought that it was isotonic and isosmolar, but when you actually measure its osmolarity, is that the right word?
Yes.
It's actually either 3, 5, or 8 times as osmolar as tissues in the body. So we actually did a study looking at all of our patients who'd had Omnipaque because we were looking for leaks in various conditions. And the people who got more than 30 cc's, I'm pretty sure, some of them developed changes in their lungs within the next 24 hours. So gastrografin is 10 times hyperosmolar to tissues. So it is absolutely contraindicated if you have someone that you think is aspirating. A story about barium. We used to use barium for bronchography way in the dark ages, even before me. And we actually made people aspirate. And you'd actually have them inhale the barium. And then you'd take pictures of their bronchi. So this was before cross-sectional imaging, where you can do high-resolution looks at the bronchi. So we actually use Omnipaque at our institution, but we try not to give too much volume.
There's an amazing image published in the New England Journal of Medicine in the last year of a patient who aspirated an entire upper GI volume of barium into their lungs, and beautiful imaging of the trees and branches of the respiratory system. But the patient died, and so I think that although bronchography is certainly the argument that I use, obviously there's too much.
Right. And I think it depends on how much you aspirate and how good your cough is. And the reports of people who've died in the literature after barium, for example, were all very, very sick and all had aspirated a lot and had no cough.
So perhaps we can put a plug in next year for a panel, international panel, around the reasons for different contrast agents, reasons for and against different contrast agents. It would be helpful to resolve the issue.
Great idea, Katrina. Well, I'd like to thank our panelists.